Hello, this is Patrick Merrill, and this is my patient interview and history audio recording. It's January 29th, 2019, and here we go. So basically, this is how I would do my patient interview and take their history in the field. So first off, I would go ahead and figure out what's going on with the patient by asking them about the history of their present illness. And a tool that we can use to do this is the OPQRST-T mnemonic. And to use that, you ask patient-specific questions such as when did this all start? What makes it better or worse? What brought it on? Can you describe the pain? Or have there been any changes in what's going on since it began? Point to it. Does it go anywhere? Does it stay in one place? Rate your pain on a scale of 1 to 10. Is it constant? Have you done anything for it? Are some of the questions that you could ask to help determine this. Also, at this point, you want to go ahead and start looking at some pertinent negatives that the patient may or may not have that could go ahead and guide your treatment of the patient, such as chest pains or shortness of breath. Next off is the medical history taking part of this. Big thing, it's going to really guide your patient care from here on out. And something that you can use to accomplish this is the sample her mnemonic. What you got to do is look at the signs and symptoms of the problem. What's going on, what do you see in the patient, what's the patient exhibiting. Ask the patient if they have any allergies to any food, environmental, or medicine. Medicine being the big one, but food and environmental allergies also can be a great help in treating your patient. You want to go ahead and determine any medications that the patient may be taking. This includes any home remedies or any prescription medication, over-the-counter, and also any street or illicit drugs. Go ahead and ask the patient about their past medical history. That's going to be a huge thing when it comes to figuring out what's going on with your patient. You want to look at the patient's last oral intake, figure out when they last ate, when they last drank, and what it was. That might be another clue that you could draw upon. The events leading up to the complaint, what was going on when this started happening. Was the patient out cutting grass, exerting physical energy, or kind of just hanging out watching TV, kind of body at rest. And also you want to look at the any bad habits that the patient might have, drug use, alcohol use, tobacco use that could bring negative bearing upon their health and possibly have contributed to this event. The environment that the patient's in, are they well kept, or are they living in squalor? Those are also very good context clues. And also some of the risk factors that the patient may have for this illness or injury. So after the sample history is taken, I would go ahead and move on to my secondary assessment, which is more focused on the chief complaint. Go ahead and start by assessing the brain, lungs, and heart, because we always check them from the start. And to do that, I would look at head, eyes, ears, nose, and throat. Look at the symmetry of the face. Check pupils equal and reactive. Any discharge of any fluid from any orifices, such as the ears or the nose. And look at the throat. Go ahead and make the patient say, ah, check that uvula. Look at the neck. Look at any C-spine compromisation. Make sure there's none of that going on. Make sure that there's no JVD that could be suggestive of something like a pump problem. Look at the position of the patient's trachea. Make sure it's midline. If it's not midline, that's bad. Listen to lung sounds in the front and back in all the fields. Listen to heart tones. assess the patient's PMS, their cap refill, and while you're down there, you go ahead and look for pedal edema. Suggest some backup of fluid or something like that. As needed during this process, regarding the patient's chief complaint, I'd look at the patient's skin, GI or GU systems, reproductive systems, the abdomen, palpate that abdomen, listen to bowel sounds, the patient's pelvis, any orthopedic processes that we may need to look at. Neurological, you can look for stroke signs and symptoms, any numbness, and you could assess your cranial nerves going down through and using those cranial nerve assessments that we learned, such as, the feel in the face, the sounds, having them smell something. All those cranial nerve assessments are very useful in the neurological assessment if that's what's going on with your patient. And anything psychiatric that may be going on with the patient if I suspect that. Next after that, I go ahead and take a set of vitals. Obviously this would be a full range. It would include temperature, pulse and respirations, looking at rate, rhythm, and quality of both of those. Good blood pressure, good manual BP. Patient's pulse oximetry, SpO2. Go ahead and perform some glucometry and get that finger stick in there. Take an EKG, put the patient on the monitor. Looking at skin, level of consciousness, and once again looking at the patient's eyes. Are they pearl? Are they jaundiced? Are they fixed and dilated and such? Those last couple ones you probably already should have assessed earlier in the assessment process, but never hurts to take a look at it again. So after all that's been done, after all those steps have been completed, and I have all of this information in my mind, I would go ahead and gather a field impression and a differential diagnosis of my patient, basically what I think's going on, and I would use that to formulate a plan for treating my patient. Once again, using everything that I gathered during the assessment process, because that's why we do the assessment. Go ahead and perform any interventions that I needed to do. Still on scene, and last but not least, I would reevaluate my transport decision based on the findings of the assessment and decide where I wanted to go from there. If I wanted to continue transporting the patient in the fashion that I originally deemed appropriate, or if I want to change that up a little bit because of what I found during the assessment. So that's my patient interview history audio recording, and thank you very much for listening, and have a nice day.